Okay, so I'm going to talk about DSO. The depender quite rightly said that really the acronym is really DSO, not really Descmetorhexis without endothelial keratoplasty. And I think this is one of the things that will probably change over the next few years, where we stick to a specific nomenclature of actually what the surgery is. These are my disclosures. They don't really pertain to what we're talking about. Maybe trefoil at the bottom, I'll talk about on the last slide in a little bit more detail as well. So DMEC, as Benny has shown, has really revolutionized the way we perform corneal endothelial surgery. We're getting better visual acuity outcomes, lower rejection rates, and less glaucoma. And there are different ways of performing the procedure. The endothelial outway is the technique that most people basically use. We use an endothelial in technique where the graft is pulled inside the eye with a pair of 27-gauge forceps and then tapped basically just gently on the surface to open the graft in its correct orientation. But the problem with both these surgical procedures is that they do require a considerable level of expertise in surgery. You do need reasonably good quality tissue to actually perform DMEC. And obviously, we know worldwide there is a worldwide shortage of corneal tissue, and 50% of people in the world have no access to tissue. And this is compounded by an aging population and an increasing global population. So we have to look at alternatives basically when we go forward. If you look at the three leading indications for endothelial disease around the world, there's Fuchs, there's bullous keratopathy, and there's basically regrafting for graft failure or late endothelial failure following penetrating keratoplasty. And these are the future concepts for replacement, really divided them into regenerative therapy or tissue engineering cell therapy. And Fuchs is really an interesting disease.
The two main concepts.
Really, Fuchs is a great example. So Fuchs is a really great example of a condition where we can think about regenerative medicine approaches, because you have early disease and you have basically late disease. Early disease, the disease is really localized to the central area. And in these kind of patients, one can consider a regenerative therapy approach, while when there's more widespread diseases and much more endothelial failure, you need to think of a more cell-based therapy approach. And this is an example of basically going through a DSO procedure, and basically why we basically need to remove the central area in somebody who has basically early Fuchs. So you can see basically from the video, you can use basically a keratome to access the anterior chamber. Viscoelastic is basically placed in, and then this is the original technique. This is an old video from a few years back now, where we're doing gentle basically scoring of the Descemet's membrane before basically peeling the area of high density guttata away basically from the central area. I'll talk a little bit about modifications in the technique in subsequent slides when we look about issues with respect to improving outcomes of the surgery as well. It's much better to peel the tissue in the central area. These are some small gauge forceps to help with the basically peeling. It allows you to get much better control of the size of the rexus, which is basically important with respect to visual recovery. And also it ensures you don't dig into the stroma like when we're doing a standard Descmetorhexis for DMEC surgery. So this concept is not really new at all. And this is a great picture taken from the Mass Eye library that was basically sent to by Roberto. And you can see that actually back in quite some time ago, Pafiq basically described a technique where he decided to basically peel off the posterior part of basically a corneal endothelium. And it's interesting, if you look at this basically figure 71 over here itself, he puts down after the first dressing, after 24 hours, one is struck by the existence of morbid edema of the cornea. So I like the word of the use morbid here. But if you carry on this, it says slowly the edema is reabsorbed and the cornea regains its normal thickness. And in the same time as transparency begins, at least partially within 1 to basically 3 months. So as in many things, I see that in ophthalmology or even in medicine, you know, this has been described by some of the great pioneers basically in the past. And this book was published in 1955. So we have to you have to bear this in mind. Now, which are the patients that are ideal for this disease? Well, any of these patients on the right-hand side over here, you can see that we can consider basically having early Fuchs. And when you can basically map out the area of central sclerotic scatter around the area of the guttata, these are your typical patients that will ideally basically do well to think of basically doing a DSO surgical technique. And primarily because the disease is localized to the central area, but the paracentral endothelial cells are actually quite healthy. And that's what you're going to basically rely to basically migrate across the surface. If you have widespread disease, like basically this one below over here, you can see there's a lot of basically scarring over here. This patient will have to undergo basically conventional DMEC surgery. So it allows you to look at your early Fuchs in a lot more detail because we have an alternative therapy that we basically didn't have in the past. This is one of the first papers. This is from Greg Maloney, published a few years back now, looking at 12 eyes, where he basically did essential DSO, a decimated stripping of basically 4 millimeters. And you can see basically from his initial cohort, 9 out of 12 cleared between 2 to basically 6 months. And there was an improvement in visual acuity in basically all cases. One basically did not clear at all, even with the addition of a ROCK inhibitor, which we'll talk about in more detail, and had to subsequently undergo EK surgery. And 2 eyes basically stalled at 3 months, and they underwent topical Repassidil, which is a more commercially available ROCK inhibitor. And this basically had clear central clearance. And the postoperative endothelial cell counts were between about 500 to basically 1299. This is one of the first reasonably large series, or albeit pilot series, of about 12 cases that really showed this basically technique work. But it also showed that in certain cases when the basically migration stalled, one required the use of basically ROCK inhibitors. This is just some examples from the paper where you can see that basically central edema or morbid edema, as Tawfiq basically described. And then you can see basically as the corneal cleared up, it becomes less morbid and much more transparent, as we're all basically used to. So I just wanted to mention a little bit about ROCK inhibitors. So what is basically a ROCK inhibitor? So the ROCK protein, it's a protein, it's a serokinase, and it's basically involved in multiple basically cellular functions. The ROCK pathway is involved in cytoskeletal functions, affects cell migration, cell cycle control, proliferation, and apoptosis. The thing is that when you apply a ROCK inhibitor to an individual cell, you're going to get a difference in result depending on the cell type. There are 2 basically enzymes of ROCK1 and basically ROCK2. They have 90% homology. But interestingly, if you look at the expression in the corneal endothelial cells, you have higher levels of ROCK1 compared to ROCK2. But overall in the eye over here, you have higher levels of ROCK2 over ROCK1. So the endothelium shows a difference in expression compared to what we basically see in the rest of the eye. And this is important when you're looking at selective inhibitors or non-selective inhibitors with respect to basically function going forward. We know endothelial cells are actually contact inhibited, and they're basically in a G1 phase. And we know there's TGF-beta2 in the aqueous humor, but basically prevents basically cells from actually basically proliferating itself. So what you want to do with the ROCK inhibitor is actually to knock the cells out of this G1 phase. And this is done by altering these, what we call negative regulators of the cell cycling. So typically cycling 1D1 to D3 ratio, and also basically reducing the effect of P27. And this allows your cells to transit from G1 into S1 phase and into basically cellular proliferation. And all of this work was done by Professor Kinoshita and Noriko Kozumi's group in Kyoto between 2009 and 2013. And they were the first to show the effects of ROCK inhibitor on basically monkey and rabbit corneal endothelial cells. So interestingly, after that, people obviously tried to start basically using it on human cells, but the results were actually quite variable. And this is one of our papers basically showing the effect of donor to donor variation, showing the variation in the ROCK inhibitor. And this is why sometimes you'll see some effect in some patients, but you won't see basically set effects in basically other patients. And when you study the effect, when you do it ex vivo on human donor corneas, you can see that you get faster migration rates by using the ROCK inhibitor compared to basically non-using ROCK inhibitor in age-matched donor pair control groups. And so you do get an increased migration speed by the use of ROCK inhibitor, but this is more prominent in older patients compared to basically younger donors. So this is the summary of basically using a ROCK inhibitor. We can use it for cell expansion, for human endothelial cells. They prevent basically cell death. This is primarily related to corneal endothelial cells. They promote improved cell adhesion, and they increase cell migration and in regenerative basically therapy treatments. And the first use of ROCK inhibitor was done by Professor Kinoshita's group, where they had one patient with Fuchs, where they used transcorneal sclering in the center over here, and then applied Y237632, which is your archetypal ROCK inhibitor, and you can see nice clearing basically of the central cornea. But the problem with this is that, of course, the cells have to migrate, and if you don't remove the guttata, then basically the cells are going to get stuck as you're going to migrate across the central area. And using basically experimental models of the guttata, you can basically show that you need to remove the guttata to basically improve the cell migration. Likewise, you can see this on ex vivo corneas, that if you apply ROCK inhibitor onto the surface, you get a much more even cellular migration of your cells. So do ROCK inhibitors work clinically? Well, the answer is yes. There's 2 papers from here, one from Greg Maloney's group and one from Mario Masrai, where you can see the comparison in study 1, where no ROCK inhibitor was applied. This is Repassidil being used in this group compared to a group basically with Repassidil. And what you can see, the clearance time improved from 13.8 weeks down to basically 4.3 in Greg Maloney's group. And likewise, very similar results between faster recovery, 4.6 weeks versus 6.5 weeks in the group without the ROCK inhibitor. there was no one non-clearance in basically Greg's group and one non-clearance in basically in Marianne's group. So it doesn't necessarily work in every single case. There are some side effects you will see. You will see some cytosolial changes on the epithelium, which I'll basically show you. And if you do get systemic absorption, you can get ocular discomfort and basically hyperemia as well. This is one of the side effects that you often can basically see on the surface. You can see this typical honeycomb epithelopathy, and you see this especially if they're using high dose levels of basically ROCK inhibitor. And likewise, you can also basically see once the cells basically are formed, you can see the pseudo-gutte formation on the endothelium over here. And this is the same representation on in vivo confocal microscopy, but this is basically what it looks like clinically. If you dig into the stroma, as I basically mentioned with the technique, initially, most people were basically using Sinskey hooks, and you disturb the underlying stromal matrix, you will get these nebula of scarring over here itself. And that's because you're stimulating the underlying or posterior stromal keratocytes. And that's why you're basically going to scarring around the edge. And that's why it's safer not to use basically a hook to do your scoring. It's better to basically use some forceps. So in summary, corneal transplantation for endothelial stains has dramatically changed over the last 2 decades. We've seen a shift from PK, obviously, to basically to EK, with less complications, better visual acuity outcomes, and less risk of rejection. Despite this, when we look at this more holistically, and we know Fuchs is the leading indication for corneal endothelial transplantation in the United States, we're looking at newer disruptive techniques in regenerative medicine, basically is at the forefront of this, especially for Fuchs, where we can get even better outcomes in selective patients with corneal endothelial disease. When you're looking at DSO, centration is important because, of course, the new optical zone is going to be formed from your basically stripping. Sizing is important. You need to peel, not basically scrape, because it will basically affect your cell migration. And of course, you still need to counsel for the chance of a graft and counsel the patient how this basically techniques will work. So I tell patients that generally this is a regenerative therapy technique, so it will depend on your old cells to migrate. There are newer drops under investigation. One of these is made by a company called Trefoil that I mentioned basically at the beginning. They're undergoing phase 1, phase 2 trials in the United States currently now. And I think we will see more drops coming to this arena in the future that will actually increase our endothelial cell migration speeds that we actually will avoid doing full thickness of endothelial keratoplasty for in the future. Thank you for your attention.
Wow,